I'm going to be introducing Dr. Karen Wingfield, who does lymphoma. She runs actually health equity at Wake Forest, and she also runs the hematologic and lymphoma sections there as well. So she's a world-renowned leader in lymphoma, and she's going to be giving us an hour-long talk today.
Thank you, Pearl. So now I'm world-renowned. I love that. Thank you. Thanks, Steve. Thank you very much. All right, folks. So good morning and welcome. I am very excited to be here. I want to thank Parul and Jason and Stephen for the invitation to come to this meeting. I probably shouldn't say this, but it's my first time being at ACRO, and I really have enjoyed all of the sessions. I mean, the speakers have been amazing. I was a little shocked to see that everybody else had a panel, and then you guys get stuck with me for an hour, so hopefully it'll be fine. You heard a little bit about what I'm doing currently. I am one of the associate directors of the Cancer Center down at Wake Forest Baptist Medical Center. I was recruited there about 1.5 years ago because of my work in health equity and the mission of my office. I direct an office for cancer health equity, and the mission is to make sure that everyone, regardless of their background, has the same opportunity to survive cancer and to survive it well. And so it's about access to care. And that has been something I've been passionate about for many years, even during my training at the Harvard Radiation Oncology program. And I stayed on faculty at Mass General to actually build the first comprehensive program in hematologic malignancies at Mass General. And what I loved about being there is having all modalities of radiation at your fingertips, from protons to electrons, orthovoltage, x-rays. But it really became apparent that it was important for us as radiation oncologists to understand the heme malignancies so that we are seen as oncologists and not just therapists, right? Oftentimes, particularly in the heme malignancies, we get relegated to being, oh, just treat that, right? We're not at the table. So my goal today is to actually make sure that we have understanding of just the basics, and hopefully I will get some folks out there to really say lymphoma is as fun as I love it. I really do love what I do. So you've heard a little bit about me. I'd love to see a little bit about you folks out there. How many folks are practicing in an academic center? Okay, how many folks in the community or hospital-based center? Very good. How many trainees do we have out there? Very good. I see you guys in the back. You guys should have moved up to the front. That's okay. How many folks actually treat lymphoma then? Oh, wow. Very good. Of those people, how many of you would say you're a heme expert? No? Okay. Let's see if we could change that a little bit, at least to get you more comfortable about the topics. Here are the learning objectives, really just to review the diverse roles of radiation therapy in the treatment of heme malignancies, to improve the knowledge of standard therapies, and then to discuss some of the challenges that we face, in particular with patient planning and dosimetry, and we'll have a few cases that we'll discuss. As noted, this is a SAM, so please take notice. I'll try to highlight when some of those questions might be coming up. Some of the fear that's associated with heme malignancies is actually a vast array of tumors that actually fall into this category, right? This is not an organ. This is not organ-based radiation. It's a system-based radiation, and that's part of what I love about it. A heme malignancy can occur anywhere in the body. So as a radiation oncologist, I have the privilege to treat this disease site, or state, if you will. I have to really think about what I'm doing in terms of both the dose that I'm delivering, but also the field size, think about both the acute and the late toxicities, because we actually cure a lot of these malignancies. You can see ALL, which is a pediatric tumor that used to be universally fatal, now we have over 90% survival rate, so you have to think about the late toxicities of what we're doing. Additionally, I think one of the challenges can be the pathophysiology. So what you'll hear over and over and over again from my talk today is the importance of having a team mentality. Heme radiation is all about having a great team, and that starts with having a great hematopathologist. And so if at your institution you are a little bit wary of what's going on from a pathology standpoint, please send your samples out. We have excellent referrals, including the NCI, Stanford, MGH. Again, I was very honored to be able to work with Dr. Nancy Harris, who has been very much involved in the WHO classifications of heme malignancies. And so it really makes all the difference in the world when you're dealing with diseases that are so complex, and you have to then think about the molecular stuff, right? we're becoming now more and more about precision medicine and standardized and personalized medicine, which includes looking at the tumor biology and pathophysiology and understanding the molecular basis of disease and identifying targets so that we can really improve the therapeutic ratio. So again, it can be daunting when you look at how many different types of lymphomas are. This is the NCCN that was actually back in 2011. As you'll notice, the new NCCN guidelines actually breaks this apart into B cells and T cells just for the ease. It makes it a little bit easier to kind of look at all the volumes that might there be. So you'll notice in the newer version that it is broken into B cells, and then T cells has their own separate section now in the NCCN. I think the other thing that makes the treatment of heme malignancies a bit of a challenge is its relative incidence in the United States, right? So if you look at all the other top cancers, and prostate's right up there with it, right? In terms of the number of cases that we see per 100,000, it's very rare, frankly, to see lymphomas. The most common, obviously, being non-Hodgkin lymphoma, which we see at probably about 75,000 cases per year. But Hodgkin lymphoma, we're only seeing 8,500 cases per year, many of which may actually have advanced stage. And so particularly as radiation oncologists, if we are not sitting at the table when there's a tumor board going on, we may not even know that there's a patient who may have benefited from our expertise. So I'm going to talk again about team. Go Pats. Yes, I see you there. Wrong shirt. And so in order to really do this in a way that perhaps folks who may have the wrong color on today may be able to hear, instead of talking about those teams, we'll just talk about the other sorts of teams that have been going on. I'm sure many of you have heard the award ceremonies going on. I haven't watched any of them in a long time, so I'm hearkening back to one of my favorite actors, Denzel Washington. And we'll talk about radiation therapy in its different types of roles, both as a supportive role, a leading role, and then also as a co-lead role. So when you think about, and this is Denzel, so this was his first Oscar, his first Academy Award. It was Glory. And for those of you who don't know, Glory was actually a movie about the 54th Regiment, which was in the Civil War, was the first all-black regiment that actually fought in the United States. And there's actually a museum not too far from Mass General Hospital that actually has a lot of artifacts from that era. So Denzel actually won his first Academy in a supportive role here. When you think about the way that we use radiation therapy, though, many of you have heard of the use of radiation for chloromas, again using low dose. Used to be called granulocytic sarcomas, a collection of AML cells that might be in bone or other soft tissue. We certainly can use it for that. Use of radiation as part of transplantation, both TBI, TLI. I've had a run, it's fascinating. There was is Dr. Healy here? One of the residents, she gave a great talk yesterday on prone breast. Anyway, I made the comment that when I made my move down to North Carolina, I had no idea that I was actually making this move to see that people's BMI is just very large. And similarly, though, the tumor biology is very large. I've not seen tumors like what I'm seeing in North Carolina, both in terms of the aggressive nature, the size of them, whether it be kind of lack of follow-up, I don't know. I'm still trying to figure out. I've only been there for a year and a half. But frankly, I've actually seen more advanced tumors there than I've ever seen in all of my training and all of my years at Harvard. And so it's been fascinating. We've had a run of people getting cranial spinal irradiation for having their CSF chock full of tumor. It's been a very interesting experience for me. Certainly, we know that radiation therapy can be used for definitive treatment. This is Denzel's second Oscar for Training Day. I didn't particularly like the movie because I didn't like the theme of it, but he's, I like anything he does, that's okay. Don't tell my husband that. But certainly for use in low-grade indolent lymphomas, definitive radiation therapy can be used. We'll talk a little bit about the dosing of that, and also some of the challenges in terms of what we can think about in the more modern era related to some of the ocular tumors, et cetera. But then also for solitary plasmacytoma. I'm not seeing very many, certainly a rare entity, but and that's probably gotten lessened because of the way that we're actually utilizing imaging to stage patients nowadays. But it's an important entity to keep in mind for us as radiation oncologist. And then finally, radiation therapy in the co-lead role, where use of radiation as part of combined modality treatment and therapy is actually the mainstay of what we do and should be, particularly for early stage lymphomas, and then also for bulky disease, including in the advanced stage. Do not forget the use of radiation therapy in refractory disease. Again, a role of radiation therapy. I've been watching people get chemotherapy regimen after chemotherapy regimen after chemotherapy regimen, and then they say, oh, this is not budging. And they just had a little tiny dot in their neck that could have very easily been treated with radiation therapy. But again, we're oftentimes not at the table. So really trying to figure out how do we create an environment that tells our medical oncology colleagues, here I am, I know what I'm doing, come and talk to me. And just because you have a hammer doesn't mean you have to use it all the time, right? So same thing from a systemic therapy point of view. Just because I'm a radiation oncologist doesn't mean that I always have to treat. So my medical oncology colleagues understand that when I say this person really needs radiation, they really need radiation, right? Because I'm not always trying to hit something because I have a hammer. So that's part of the art of really getting to mobilize around heme malignancies and creating that team approach. Just a reminder that the stage of lymphomas really hasn't changed. We're still using the Ann Arbor, but it's slightly modified. Remember, you can have 1 or 2 disease sites above or below the diaphragm as early stage is how we categorize it. Anything where you have above and below or you have diffuse organ involvement is going to be stage 4. Anybody know the Lugano classification? Anybody heard about that? Okay, so this has been slightly modified. So for those of us who are heme radiation oncologists, we get dragged kicking and screaming every other year to Lugano, Switzerland, where we actually have a conference there, and we actually talk about the heme malignancies. Includes both radiation oncologists and medical oncologists, but we get together and talk about things. And it's an important thing to notice that even though stage 2 is typically thought of as early stage disease, in the update of the Lugano classification, which came out in 2014, and I'm going to put references in here for you guys so you can look up. All right, most of this is going to be providing references for you. If you have stage 2 bulky, that may actually need to be treated as a more advanced stage. So stage 2 bulky, and that's particularly if they also have other increased risk factors or including like B symptoms or systemic symptoms, okay? So that's important to remember. So here it is. This is actually the Lugano classification. Here is the reference for you to kind of take down. That's Chesson et al. It actually talks a lot about staging. How do you stage? How do you appropriately follow up patients? Oftentimes what I see is my med-onc colleagues will get PET scan after PET scan after PET scan, and that is no longer how we follow patients. So I think it's important for us to understand how to stage and how to follow patients so that we can help our teams do what's best for the patients and also help with respect to ensuring that we are cost effective in the way that we care for our patients. There has been a slight refinement of the Lugano classification, much of that related to a lot of the newer targeted therapies. So immunomodulatory therapies or immune therapy, as you know, is huge, particularly in the heme malignancies. Probably most of the last FDA new treatments actually are for heme malignancies, particularly CLL. So there has been some modifications to the classification. And so these are some of the new things, again, the standard staging, the response based on the 5-point scale. Most of you have heard of the Deauville scale, Deauville classification, particularly the residents need to understand how to use it. I'll actually include a slide of that next. Also kind of talking about the modification from the Ann Arbor classification. We no longer are using X. Oftentimes that was kind of for bulky disease. I still use it just because that's how my brain works. But oftentimes what people are doing instead is indicating how large the site was. Remember, in Hodgkin lymphoma, it's still 10 centimeters is still the cutoff, but not for non-Hodgkin lymphoma, not in the CT era. It's 7.5, 7.5, and you'll see some studies that actually use smaller, particularly if it's in the neck. They may even go down to 5 centimeters to designate bulk. So it's really important to kind of understand that difference. One other important thing, bone marrow biopsy no longer needed. Okay, particularly for Hodgkin lymphoma, where PET imaging, since that's part of the staging, if you're getting a PET, you no longer need to do a bone marrow biopsy because it's been shown that actually PET is more sensitive than doing a bone marrow biopsy because of the way that Hodgkin lymphoma will do skip lesions. So you may actually get a bone marrow biopsy but miss disease in Hodgkin, right? Because remember, when you have a big bulky node in Hodgkin lymphoma, the majority of that is actually not tumor. Fewer than 1% of the cells in a bulky node in Hodgkin lymphoma are actually Reed-Sternberg cells. The majority of what you see is actually inflammatory response. So you stick in needles and stuff, and that's why we actually do excisional biopsies and not needle biopsy. We never do needle biopsies for heme malignancies because you get something and you don't know what you're getting, okay? So that's an important thing. And then, as I mentioned, the routine surveillance scans being discouraged is also part of what came out in this classification. Here's the Deauville criteria. If somebody wants to take a picture of that for their records, that's fine. And then I'm actually just going to move on to show you what this looks like. So this was a 20-year-old woman who actually was diagnosed with Hodgkin lymphoma. You can actually see she has disease above and below the diaphragm, a few areas there in the right iliac crest. She has one area in her spleen. Is this stage 3 or 4? 3 or 4, splenic involvement. Who says 3? Who says 4? Wrong. You know why? The spleen is actually part of the is part of the immune system, right? It's actually considered a lymph site, right? So remember that just because you have splenic involvement does not mean that that's stage 4. Okay, stage 4 actually is involved when you have lots of disease in the bone, etc. Those are essentially iliac nodes. It's hard to tell because you weren't able to rotate the MIP. So for those of you who thought there might have been bone involvement, perhaps we could have gone 4. Okay, so that was a trick question. You'll see how bright and avid things are on the left panel, but here this person just had 6 cycles of ABVD, and you see there's one little bright area that's still there. And so how would you classify this from a Deauville response? How many say 3? How many say 4? How many say 5? How many don't know? Okay, so the Deauville is actually related to what the uptake is in the mediastinum versus the liver, okay? So if it's greater than what you see in the mediastinum, but less than what you see in the liver, then that's a Deauville 3. And that's kind of a weird category because that's the one that in some studies will actually make a person have to come off study because they haven't had a good enough response. However, this person essentially has had a partial response. You see most of the disease has responded very nicely. That one little node that's up there, I would classify that as a Deauville 4. Okay, it's not brighter than what they initially started out with, which would be a Deauville 5, and that would indicate that they then have progressive disease. This is just a partial response. So this is somebody that unfortunately, if our medical oncologist colleagues saw this, they may actually say we need to give a different type of chemotherapy. I would say this person needs consolidative radiation, and they might need a dose that's slightly higher because, you know, it's not going to be 30 gray. They may need 36 to 40 gray, but they would need radiation therapy to just consolidate that one side. Okay? So that Deauville criteria really helps us figure out how do we treat an individual, and that's an important thing for us to kind of wrap our brains around. We talked a little bit about all of these new targeted agents. And this is the one area, again, as I mentioned, the Lugano classification has changed because some of these agents will actually cause an FDG flare. So it's really critical if people are on any of these agents. You're starting to see more brentuximab vedotin, which is used in Hodgkin lymphoma. It's a CD30 antibody that is used for patients who've had a primary refractory or relapse disease, particularly itolizumab also, which is one of the ones that we see in ibrutinib. We sometimes will see that in non-Hodgkin lymphoma. You can get actually an FDG flare. So again, you have to be cautious in the use of some of these newer agents in terms of how this PET scan is read. This is, again, where it's important to have great relationships with our colleagues in radiology. So our nuke med folks, we kind of make sure we have a good coordination with them, and then collaboration, and then also talking with our med-onc colleagues about whether or not this could really be a flare or if it truly is progressive disease. So let's talk a little bit about the history. I'm not going to go into this very much, but what's fascinating is that, remember, Hodgkin lymphoma used to be uniformly fatal, right? So back in the early 20th century, if a person was diagnosed with Hodgkin lymphoma, only about 5% of them survived up to, at 5 years. And it wasn't until the use of radiation therapy where we got survival rates up to the 50s with the use of radiation therapy. Now, granted, it was very large fields, but it's so funny how far the pendulum has swung. Back in the day, lymphoma used to be one of the bread and butters for radiation oncologists. And so it's really this slide which has caused the pendulum to swing the opposite way, where we started to see, although we were curing Hodgkin lymphomas, you see actually that kind of flat line where people were dying from Hodgkin lymphoma at much lower rates. The rates of cardiac disease and particularly second malignancy rates went up. So what was happening is while we were curing their Hodgkin lymphoma, we were actually causing them to have a lot more second malignancies. But bear in mind, this is what we were doing. And so I actually have some patients that I'm seeing in follow-up were subjected to some of this total nodal irradiation, where we were actually treating very large swaths of tissue. And so it's really important to remind our medical oncology colleagues and patients that we no longer do this. If you're doing this, come and see me after. We'll have a chat. Okay? So there are very few reasons now to do total nodal irradiation. I did have it as one of the things we do it. We do very low dose, literally like 80 centigrade per day, when we're actually looking at doing regimens in preparation for bone marrow transplant. There are a few centers that are still doing that, but it is very labor intensive, and for 80 centigrade to kind of prepare the bone marrow, a lot of times people just were moving to TBI. So, but these are the old ways that we used to treat folks. And then we started to move towards involved field radiation therapy. And so many of you may remember the Malki-Holland paper where they kind of, told you the borders. And so it's like imprinted in my mind. If you have somebody in the neck, you have 1 centimeter below the mastoid tip, 2 centimeters below the clavicle, right? You kind of remembered everything by anatomic boundaries because it was mostly 2D. But we're in the CT era. We're doing 3D, so why not use all of those tools to make sure that we're actually able to identify, target the tumor, and spare normal tissue? I showed this because if you look at the skin rendering on the bottom, this is the female, so that was that 20-year-old, remember, showed that large field. If we were treating the axilla with an involved field, look how much of her breast would be in the field. So even with involved field radiation therapy, despite it not being kind of total body, we were still putting people at risk because of the field size. And remember, it's the integral dose, the field size, that actually determines the person's risk of developing second tumors. And look now at what we're doing with involved nodal radiation and involved site radiation therapy. So we'll talk a little bit about some of those guidelines, and I'll give you the references for that so that you can kind of make sure that you guys have a good understanding of now what we're doing. What is the modern radiation therapy for hematologic malignancies, and in particular lymphomas? We do use three-dimensional therapies, and so it's important to make sure that we're doing that and not just sticking with the old kind of way of doing things because it's easier. It helps us to better visualize the tissue, but also helps us when it comes to the late toxicities, both acute and late, right? So avoidance of tissues, normal tissues, contouring out breast tissue for young women may be something that is important, but also, more particularly, the cardiac tissue is really critical for folks who have mediastinal disease, but when you get in the head and neck region, making sure you're sparing the glands so that people don't have long-term xerostomia, et cetera. This is actually an important thing too, is fusing. So yes, we do use PET scans to stage, so why not take those and actually fuse them? One of the vendors that was here was the MIM group, and actually, so we use MIM, and I use it because it has deformable registration. I love it, right? So many of you may be using it for other disease sites. I love it, particularly for my head and neck patients, but I use it for any of my patients who have heme disease where I can actually fuse. Sometimes the deformable registration is not off, so you still have to use your noggin and think about where things are anatomically, but it's a great way to actually help to simplify some of the planning if you actually fuse the PET imaging. And actually, there are lots of little bells and whistles with the MIM program, which will allow you to actually think about just capturing where the PET avidity was as a starting point. I'm going to show you how to kind of adapt to what you're doing with the PET imaging and after they've had systemic therapy. But don't forget to use advanced treatment techniques. There's nothing wrong with using IMRT, even for lower dose. I mean, it's interesting, when you make a transition to a new facility and you get challenged. It's like, well, why are you using IMRT for 30 gray? I'm like, well, why not? My patients get through therapy better, right? They have less toxicity. If I can prevent xerostomia, if I can prevent, abdominal cramps, why not? And so it's a way to actually use the modalities that are there, but you have to make sure that you're thinking about what your target is, and that's where sometimes I think people get nervous and they go back to the involved field because there is some weirdness with the new involved site radiation therapy. Also using particle therapy, so if I have somebody who has a conjunctival malt, I actually use electrons, particularly if it's limited to the conjunctiva. Make sure you get some good orbital imaging to make sure there's nothing in the lacrimal glands or anything around there. But if you can, use electrons, and it works beautifully well, and people don't have a lot of toxicities. You can see the old ice cream cone on the right, where you have the x-rays. You're getting all that low-dose spray into the brain. You don't have to do that if you can actually use particle therapies. As I mentioned, I was at Mass General, so I had the blessing of being able to use protons, which for some of my patients who had facial tumors, if they had follicular lymphomas in the nasolacrimal sac, and being able to use proton therapy to actually treat that area without treating the orbit, without treating the brain, that actually benefits patients. But again, using our techniques judiciously, so we're not just using them as a way to bring in cash, but using them really to make sure that we're taking care of patients in the best way that we can. I don't actually use protons for groin, I don't know that you need to do that when you can use electrons or photons, but for some of these sensitive areas, I think it would actually be beneficial to patients to actually think about the use of particle therapy. So let's talk about the guidelines for treatment fields. And this is where people get hung up. So residents in the back, make sure you're paying attention. You will be tested at the end. So ILROG. Anybody hear of ILROG before? Anyone? Okay, a few hands, good. So the International Lymphoma Radiation Oncology Group, which was formed several years ago by Yahalam and colleagues. Dr. Lena Specht there wrote these guidelines along with the colleagues to really help to delineate how we're using CT-based planning for lymphomas. This is a critical piece for those of you who do treat lymphomas to actually take a peek at. There are some examples that are inside the paper. They talk about boundaries, et cetera, but just the same way that we treat everything else, outline what the CTV or the GTV is. The challenge with lymphomas, remember, they're getting chemotherapy many times before they come to us. So what's the GTV, right? And you don't do that. It's a pre-chemo GTV that gets outlined, and then you actually conform the CTV to the tissues. And I've got an example here to kind of show what this looks like. So remember, back in the day, this would have been treated, if this were a tumor that somebody presented, they would have gotten a mantle field, right? So they were treated a whole lot of tissue that wasn't involved. So now what you do is you actually take your pre-chemo imaging and you fuse it with your CT planning imaging, and then you outline essentially a pre-chemo target. Then what you're able to do, based on these guidelines, is actually then to shave it out of tissue that was uninvolved at the time. So remember, lymphoma pushes. It's a pushing tumor. It doesn't really invade. Occasionally it does. There are some examples where it invades, and that's where you have to be thoughtful. But for the most part, it just pushes. So you can have a tumor that's pushing lung tissue, push, 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 and it's sitting out inside the chest wall cavity, but after radiation, after chemotherapy, that tumor shrinks. Do you need to treat the lung tissue? No, because that wasn't involved. It just had tumor pushing against it. So you want to treat the area where the tumor was abutting, but being thoughtful about the normal anatomic boundaries. And this is an example in the axilla. And this, I think, is in that paper where you can actually see where this patient had tumor that was in the axilla, very bright, and then after chemotherapy, it went away. They still need consolidative radiation therapy. And you can see on the top right, if you actually just outline where the pre-chemo disease was, you're actually including muscle tissue that really is not part of your CTV, and then you can actually see on the bottom right how you actually constrain the actual outline of what your CTV is. Now in the axilla, people are like, well, who cares? You know, your field is going to be essentially the same whether you have that big blob there or not. Well, that's fine maybe in the axilla, but what happens when you're in the head and neck? What happens when you're in the mediastinum? When again, you have to think about what you're doing in terms of the dose of normal tissue. Those are the reasons why these guidelines are very important. Remember, you can have lymphoma anywhere, and you have to be getting in the mindset of actually thinking about what you're doing, why you're treating, and why you're treating it. This is the second paper that I want to point out. This is the Illich paper. This one is actually specifically around non-Hodgkin lymphoma. There are some slight variances that you'll see between Hodgkin and non-Hodgkin lymphoma. Remember, Hodgkin lymphoma tends to be one that actually moves from nodal group to nodal group. And so there oftentimes are different ways that we can look at things. I frequently will make sure that I'm looking very carefully at the CT scans, both before and after treatment, to look to see if there are any weird things, schmutz I call it, that may be nearby that may not look like it was involved. Remember, we still have limitations to our PET scans, and so a lot of these guidelines will allow for that clinical judgment that you may have as a clinician when you see somebody. It's like, you know what, I don't know whether that's really FDG avid, I don't know whether that, it looks slightly enlarged, but kind of taking that into consideration. These guidelines help walk you through that process. And this is just another example of somebody who has disease in the axilla on the top, and then one who has a disease in the groin on the bottom. And again, you can see the pre-chemo volume, then the post-chemo planning PET, and then how the volumes are drawn. What I don't like about this, and I hope they fix in the next iteration, is you can see the PTV is actually extending outside of skin. So in many institutions, what would you do? You'd bolus it, right? There's no need to bolus this, right? If it's not coming out of the skin, there's no need to bolus. It's one thing if it's involving the skin. And so I just want to remind you, I know the skin talks were great yesterday, by the way. They talked about not needing to bolus if your volumes don't come out to the skin. I would shave this at like 3 millimeters so that you don't have to worry about that. And then you can see on the bottom in the groin, same thing. I would shave the PTV back so that you don't have to worry about bolusing that tissue. But these are all in that paper there, so you can understand how to kind of think about through the contouring. And then finally, this is actually looking at the guidelines from ILROG around extranodal sites. And this is one that actually causes folks a lot of consternation, right? Because, nodes, okay, we understand nodal patterns and nodal basins, but sometimes when we get into extranodal sites, then what do? This paper, which is, Yahalam was the first author on this, and it actually is I actually reference this not infrequently for my patients who have NKT cell lymphoma. So my bias, frankly, though, folks, is that patients who have NKT cell lymphoma, particularly if it's stage 2 or more, needs to be seen at a tertiary center. And let me tell you why. I had a patient who actually had an NKT cell lymphoma that we started very, very quickly, and her palate fell out week 2 of treatment. Her palate, right, because it was involved with tumor. In the community setting, unless you have really great ENT, and you may have great surgeons and people who can make obturators and all that kind of stuff, that may be fine, but remember, NKT cell lymphoma used to be called lethal midline granuloma for a reason. It literally eats away at the tissue. And so these actually respond very quickly to radiation therapy. And my bias is always to start with the radiation, but I know a lot of folks are doing SMILE, which is this chemotherapy regimen that has an asparaginase-based regimen. And that's fine for some, but frankly, the radiation is what is curing these people. The adjuvant chemotherapy adds to, but I really think these patients need to start with radiation therapy first, if possible. Sometimes if they have CNS involvement, you really do need to get the systemic therapy, but again, this is where the team approach comes in, you have conversations. But again, my bias for NKT cells, particularly if they're stage 2 or more, where they're kind of involving some of those structures, including the palate, they probably need to be referred to a center that sees them more frequently. And this is a patient, just to show you how quickly these respond, this is a patient of mine who actually had an NKT cell that was involving the bulb of the nose, and actually after 2 weeks, she had just an amazing response. What happened over time, though, is after treatment, that area of her nasal ala started to recede, right? Because it was actually filled with tumor. So the tumor had eaten away the normal tissue, and then as that went away, that tumor contracted, or the volume contracted, as did the tissue. And I ended up needing to send her to a plastic surgeon to actually get that fixed. So the importance is, and I actually make sure I see my patients back. Again, in order for us to make sure that our colleagues in medical oncology don't see us just as technicians, we need to be following our patients. So I actually follow my patients, particularly those who have the NKT cell. Remember, these doses are about 50, 54 gray, depending on if they use SMILE. SMILE, you're going to go to a lower dose because it's a much more toxic systemic regimen. At Mass General, we were using asparaginase-based regimen with methotrexate and dexamethasone. And that was done out back, so patients did a little bit better. You can also use R-CHOP as a chemotherapy for these. But the bottom line is that these regimens are very intensive, and you want to make sure you're following your patients, talking with them about speech therapy should they have involvement of any of those organs. So it's important for us to make sure we're following our patients. So now let's get to lymphoma. Let's talk a little bit about early stage Hodgkin lymphoma. Some of the questions that oftentimes come up is, well, do we use combined chemoradiation therapy, or is chemo alone sufficient? If you're using chemotherapy, what type of chemo and how much? What about radiation? Where are the fields, doses, all that kind of stuff? And then we now are hearing more about PET adaptive therapy. And there have been several prospective clinical trials that have looked at the use of PET to see whether or not usage of PET imaging can actually help to delineate the favorable patients, those who may not need adjuvant radiation therapy versus those who may have more aggressive disease that may actually benefit from radiation therapy. And so this study here, and remember those SAM questions that we talked about. I want you all to assume, if you ever see a SAM question that talks about Hodgkin lymphoma, to assume that the patient you're reading about actually has favorable disease, okay? That was not clearly outlined there. But this is a study for favorable disease, and so remember, the German Hodgkin study group has done an amazing job at really changing how we think about Hodgkin lymphoma because they have the capacity to do that. A lot of times in the United States, it's really a challenge to do prospective clinical trials on Hodgkin, number one, because it's so rare, but also because our patients are all over the country and there's physician bias, and it's really hard. So the Germans have done a great job at consolidating a lot of this work. And this was a 2x2 factorial where they actually compared chemotherapy regimen versus radiation. So how much chemo versus how much radiation. So it's a 2x2. And it's comparing 4 cycles of ABVD versus 2 cycles of ABVD, which is ABVD being the chemotherapy that we use most frequently here in the United States, versus 30 gray of involved field radiation therapy, or 30 gray versus 20 gray of involved field radiation therapy. And again, this was involved field, so it was a larger field. And what they showed is that usage of 2 cycles of ABVD followed by 20 gray of involved field radiation therapy was not inferior, so it's a non-inferiority trial, not inferior to giving 4 cycles of ABVD followed by 30 gray. Okay, so this was practice changing. So for early stage Hodgkin lymphoma that's confined to 1 or 2 nodal groups above or below the diaphragm, the standard of care is to do ABVD followed by 20 gray of involved field radiation therapy if the person does not have risk factors. And what are some of the risk factors? Bulk, right? Elevated SED rate, patients who may have B symptoms, so systemic symptoms, those are the ones who would actually be disqualified or would be actually in the more unfavorable group. But still the German Hodgkin study group has an answer for that as well, and they did a similar study. Now this study that was for the HD11, which is the other trial, so remember that one that we looked at for early stage Hodgkin, favorable was HD10, HD11 looks at the unfavorable group or those who have risk factors. They actually found that ABVD times 4 was sufficient, but followed by 30 gray. So they looked at 20 gray in that cohort, and 20 gray was not sufficient. They had a lot more of progress, disease progression in the group that only got 20 gray of involved field radiation therapy. The one thing I didn't like about this is that they actually escalated the chemotherapy. So if they actually, the other arm, it wasn't just comparing ABVD times 4, they actually did BACOP in that study. And BACOP is a very good regimen. Germans actually use it quite a bit, but it's one of those things that has a lot more toxicity. So again, for what's the incremental benefit? It's fascinating how they'll jump to BACOP, but they don't want to do radiation because they're like, oh, the toxicity. But it's, all right, I'm not going there. So again, well, do you even need radiation? So these are the old school trials. This is kind of looking at the trials of chemo alone versus combined modality therapy. And I kind of circled this trial from India because it actually is probably one of the only trials that showed an overall survival benefit, the use of radiation therapy by in and of itself. You can see when you don't use radiation therapy, the event-free survival was 76 versus when you do, it's 88. So you actually improve event-free survival. But then looking at overall survival, it goes from 89% to 100%. And so they're like, oh, well, that's just a small difference. I love how they interpret these studies. But you talk to a patient, they're like, yeah, I'll take the 100% survival, please. Yeah. And so what oftentimes I'm kind of relegated to going to a meta-analysis. And this HERPS meta-analysis is a great paper for folks to reference that actually shows the benefit of adding radiation therapy for patients who have Hodgkin lymphoma. And it did show that there was both an improvement in progression-free and overall survival. There is, again, a move to say, can we use our advanced staging and scans to really predict which patients are going to do better? And in fact, we know that for Hodgkin lymphoma, the interim PET after second cycle of chemotherapy is prognostic. Right, we know that there's a prognostication when you actually have 2 cycles of ABVD. People who have a complete response after 2 cycles of ABVD will do better. Okay, but that doesn't mean they don't need radiation. And so these prospective trials have been actually designed to look at that question. Again, they kind of tweak stuff a little bit, which makes it hard when you're trying to compare these studies. But this is the RAPID trial, which is looking at early stage Hodgkin lymphoma. Again, no bulk or B symptoms, no prior therapies allowed, but then they were looking at ABVD times 3, so 3 cycles of ABVD, followed by PET, and then patients get randomized. So if they're PET positive, they get a 4th cycle, and then they go to involved field. So standard HD11, right? So that's what they get. If the PET scan is negative after 3 cycles, then they get randomized to observation versus no further treatment. So it's odd. So at HD10, we see 2 cycles of ABVD followed by radiation, and then they're adding 3. So again, hard to compare things, but no further treatment versus involved field radiation therapy after 3 cycles of ABVD. And what they show is that in this study, you can see, again, radiation therapy actually improves progression-free survival. And this was in the New England Journal. Again, people say, well, it's not a big difference because overall survival is not really statistically significant. But again, if you talk to the patient about what they want, remember, if a patient relapses, what do they go through? Salvage chemo followed by stem cell transplant, right? So you're going to get a high-dose chemotherapy followed by autologous stem cell transplant in the relapse setting, and that's a lot of treatment. And so again, if you talk to patients about whether they'd rather come back and have all of that versus like, no thank you, they usually go for the latter. So Just to recap, management of Hodgkin lymphoma in 2018 now. Hey, I should have updated my slide. It is a very highly curable disease. Affects mostly young patients. We do obviously know that it's a bimodal disease. We're seeing a lot more in patients that are older. I've had a couple of 80 octogenarians, which has been interesting. But treatment regimens have to balance the issues of disease control and versus the late toxicities of treatment. The acute toxicities we can tend to get people over, but it's the late toxicities that we really have to be cognizant about. And the adaptive therapy, remember HD10, the results are out. I'm kind of looking again at adaptive therapy. I didn't bring it up because they used BA-CUP in that study again, and I just didn't feel like it was appropriate, but you feel free to look that up. All right, non-Hodgkin lymphoma. This is where the rubber meets the road because this is where we actually see most of these patients, right? Most of the patients that come through our doors are going to be patients with non-Hodgkin lymphoma. As we saw earlier, most of those are going to be a B-cell variant, but we are seeing T-cell, particularly in this cutaneous lymphoma. And so the way that I like to kind of categorize this in my brain is thinking about aggressive tumors versus those who are more indolent, and then maybe those who are variable. Mantle cell is included in the aggressive. It's gotten a pretty bad rap. There are actually 2 different types of mantle cell, or maybe even 3, depending on the molecular analysis. So there is some variant of mantle cell lymphoma that actually is kind of more indolent and can be treated kind of more similar to a standard DLBCL, but most of them are going to be more in the aggressive category, particularly if they're seeing us, if those of us who are working in the community setting, they're not going to come to you, a mantle's not going to come to you unless they are really refractory to therapy. So I'm just pointing that out. But you can see the follicular and the marginal zone and the SLL, CLL categories. Those are the more indolent, slow-growing tumors. And we do some pretty good stuff, particularly with follicular and marginal zone lymphomas I'll tell you about. But first, we're actually going to start with the aggressive tumors. And again, if they're localized, just the same way with Hodgkin lymphoma, localized disease is going to be combined modality therapy. It really should be. For those who have stage 1 or 2 disease, it's really important. Again, you have to use all the tools at your disposal. For DLBCL, if they have an early stage tumor and their PET scan is negative, you still need to get a bone marrow biopsy in that setting. And the reason why is because getting that bone marrow biopsy may change your management. Right? So unlike Hodgkin lymphoma, where you have clear data that shows if your PET scan is negative, you don't need to get a bone marrow biopsy, we do not have the same for DLBCL. All right? So diffuse large B-cell lymphoma, because it would change your management, because we treat based on the stage for localized versus advanced, it's really important to make sure that that gets done. They also can be discordant marrows, because remember, a lot of times, if a patient has follicular lymphoma for many, many years, there can be a Richter's transformation that actually cause that tumor to become more aggressive, and it gets transformed into a DLBCL. So while you may be treating the more aggressive tumor, and that may disappear, that person may have follicular lymphoma that you may have underdiagnosed, and therefore may have progressive disease, and it can confound things. And you may need to have a slightly different treatment approach when a patient has 2 different types of lymphomas. So when we think about DLBCLs, this has even gotten more complicated in the recent era because of the molecular diagnosis. Remember, you may have heard of double hit or triple hit. Those are diffuse large B-cell lymphomas that actually have a MYC rearrangement. So if you have a MYC, that actually, those patients who have both a MYC and a BCL2 or BCL6, that's called a double hit, so one or the other, BCL2 or 6 with MYC is a double hit, and those patients have a much, much poorer prognosis. Now in DLBCL, if they have stage 1 or 2 disease, 90% of these patients are going to be alive, right? I mean, we are really curing a vast majority of these early stage, but not when they have that double hit. And they have what's called double expressors. Those are patients who may not have the actual genetic transformation, but they're actually overproducers of those proteins, and those patients actually also have poor prognosis, but not to the same level as the double hit. So again, important in DLBCL to make sure that the appropriate molecular studies are actually being done so that we can figure out how we're going to treat. So when you look at the molecular, people may have heard of ABC versus GBC, so that's the patients who have the different types of molecular signatures. Those who have the germinal center B-cell DLBCLs have a much better prognosis, and that is the majority of patients. Those who have the active B-cell, activated B-cell, those actually are the poor prognosis, but many of those are the double hit or the triple hit, okay? So just remember ABC, poor prognosis, the GBC have a better prognosis or more standardized prognosis, but still important to make sure that we're looking at the molecular signatures of the tumors so that we can help to think about chemotherapy. Those with double or triple hit are getting dose-adjusted R-EPOCH. Okay, so that's an inpatient chemotherapy regimen that people are getting. Some of you may have heard about it from primary mediastinal B-cell lymphoma. So back in the day, when I was at Mass General, I actually had a prospective clinical trial looking at the use of proton therapy for mediastinal tumors or mediastinal lymphomas as a way to spare cardiac toxicity. And the reason why I did that is because I was seeing so many primary mediastinal B-cell lymphomas. I mean, we've had maybe 10, 15 a year. It was just amazing how many young women in particular, because remember, this was mostly in young women who would have this disease. And then a study came out, the Dunleavy trial, that really changed practice patterns. And what that study showed is that instead of doing R-CHOP, it used to be R-CHOP times 6 followed by involved field radiation therapy. But that study showed, the Dunleavy trial showed that if you actually give patients dose-adjusted R-EPOCH, 6 cycles, and the patient has a CR to therapy, you can obviate radiation therapy. So again, as a radiation oncologist, I'm like, actually, that's great. I would love to not have to give patients radiation, particularly a young woman who, you'd think about cardiac toxicity or toxicity to breast. But it did change practice patterns. And so, I ended up having to close that trial because we weren't accruing as many patients because it just, our volume went down. So the dose-adjusted R-EPOCH is actually very nice. It's a very well-tolerated therapy. They actually scale it up. So for older individuals, you may see dose-adjusted R-EPOCH, but again, you'll also see it in the setting of patients who have double-hit DLBCL as well. It works very well. It melts these tumors, and for most patients, they actually will not need to have radiation therapy afterwards. You all know the prognostic models. People talk about the IPI, really using in the post-rituximab. Please make sure you're using the revised IPI. It just is a way, again, to delineate patients and to prognosticate. Some people are using this to help to determine what the treatments are, but most of the time it's really just about how we're actually going to follow the patients longitudinally. And then you can see for the guidelines for DLBCL really haven't changed very much, even in the era where we are looking at adverse risk factors. So that really doesn't impact very much using the prognostic scores for everyone. In early stage disease, again, hearkening back to how we got to where we are, looking at chemotherapy plus or minus radiation, all of these studies showed an improvement in progression-free survival with the use of radiation therapy. But as you'll notice, every single one of those drug regimens was without rituximab. So rituximab, a monoclonal CD20 antibody, which is discovered, actually really changed things quite a bit. As you know, these B cells have the CD20 marker on there, and that targeted therapy is very well tolerated, and people are like, well, in the rituximab era, we don't need to use radiation therapy. So that's another argument you'll get, right? We don't need it because we now have rituximab. What's fascinating, and I took these slides from Dr. Eng, who's one of my mentors over at Dana-Farber, and she's been a great collaborator and colleague. But in some ways, she says that having better drugs means we really need to have radiation on board, right? So if you think about what happened, so back in the day when we were just using CHOP regimens or CHOP-like regimens, everything we thought was apparently localized. Even with PET imaging, there are limits, remember, to what we can do with our imaging, where you actually give a person upfront systemic therapy and you consolidate. We're assuming that we're getting everything in that local field. We're consolidating the areas of bulk, but we still may leave some residual disease behind. In the era where now we have these targeted therapies, it becomes more important to make sure that, particularly for areas of bulk, and you see this is a patient who has diffuse disease, so this is stage 3, areas of bulk, consolidating that because we're assuming, and it's safe to assume, that we're actually getting better systemic therapy to these patients, and so it means that the local therapy becomes even more important. So this has been borne out in several trials. This is actually the MINT trial was done by the GILA group for patients that were up to age 60 and looking at, it was CHOP plus or minus rituximab. So it was really more of a chemotherapy kind of trial, but they did use radiation therapy for patients who had bulky disease or those who had extranodal disease. Similarly, the Recover 60 trial was actually looking at the same kind of thing, CHOP plus or minus rituximab, but in patients above age 60. And what was shown is that they did a subgroup analysis, and this particular one was actually just looking at patients who had skeletal involvement. So if you had bone involvement, the addition of radiation therapy actually improved both event-free and overall survival. So that's what these curves are looking at. But also, if you looked at multivariate analysis, the addition of radiation therapy for the entire group reduced the risk of an event. If we'd actually just focus on the RECOVER trial, again, looking at the different arms there, comparing chemotherapy plus or minus rituximab, again, a retrospective subgroup analysis of patients with bulky disease, and again, bulk being defined as greater than 7.5 centimeter here, that those patients actually did much better when they had radiation therapy. And here are those curves, okay? So clearly, the addition of radiation therapy, what's fascinating, again, if you look at the intention to treat, so clearly there was some little bit of physician bias. So despite the fact patients were enrolled in a clinical trial, or maybe the patient said, no, you're going to give me some radiation. Maybe that's what happened. But if you compare what the intent to treat versus what happened, what actually the patients got, the patients who got radiation therapy did much, much better. And so it was actually more significant in the per protocol analysis. There's also an additional study, Unfolder trial, again, looking at patients who had bulky disease. This one is actually comparing the RCHOP21, which is, again, is pretty much standard here in the United States, doing a 21-day cycle versus the 14-day cycle. They were checking to see in this study whether accelerating the course of systemic therapy actually improved outcomes. It wasn't really significant enough, so a lot of institutions, including Mass General and my own, we actually do the 21-day cycles, but that's institution. This is actually a prospective randomized trial that's ongoing, but what's fascinating about this is that this actual study was actually stopped early because in patients who were not getting radiation therapy, look what happened. There was actually a difference early on, enough where they actually had to stop the clinical trial and close that arm down. So they're still accruing patients. We don't have all of the data, I don't think, has come out yet for this particular trial. But again, for patients who have DLBCL, early stage, it's kind of easy, right? 3 cycles of R-CHOP followed by involve site radiation therapy to 30 gray. I'm going to show you some data around that. Not 36, not 40, not 45. 30 gray, please. 30, yes. But that's kind of an easy one. It becomes harder with patients who have bulk, particularly if you have mediastinal disease. And you have to be thoughtful about this. There has to be, particularly if you have mediastinal disease and a young person, being thoughtful about what you're doing is really helpful because of the late toxicities or potential for late toxicities. But definitely for bulky disease, you want to make sure you're consolidating the bulk. Stage 3 disease, Sam? Oh, yeah. Oh, sorry. So stage 3 disease, consolidate the bulk, okay? And you want to do that with doses of 30 to 36 gray. In fact, the NCCN guidelines talk about that, okay? So consider adding the radiation therapy for those. This is the study I was telling you about. I love the Lowry study. My residents in the back, I know Dr. Sullivan, I think I saw you there. You know the Lowry, right? I talk about Lowry all the time. This was practice changing for us because it really did a wonderful job. There's a prospective clinical trial comparing dose regimens for both aggressive and indolent tumors, right? So for an aggressive DLBCL, remember, we were treating patients to doses 40 gray or more. We don't need to do that. And this study shows that. There was not any inferiority by using less doses or lower doses. So really what we're doing now is 30 gray for consolidation of DLBCL, okay? For indolent tumors like follicular lymphoma, even in the setting where you're treating the indolent tumor with definitive radiation therapy, this study shows you don't need to go to 40 gray. 24 gray is sufficient. So all of my patients who have follicular lymphoma are either getting 24 gray or getting the boom boom. Who knows the boom boom? Right? 2 gray times 2. It works. It really does. It's fascinating how quickly this works. And in fact, there are some institutions, including Yahalem at Memorial, who's actually using it for ocular tumors because it really does well. And it doesn't preclude you from coming back and treating should there be a relapse. But I'll show you some data that shows that about 80% of people have response with that lower dose. I'm going to move past that. Let's talk about let's see where we are with time. We're getting close. Remember to use some advanced conformal radiation techniques. I mentioned proton beam, but also IMRT. But in institutions that don't have proton beams, what are some other things that you can use? Deep inspiration breath hold has been wonderful. If you have the capacity to do it at your institution, there are a lot of ways that you can actually help them monitor patients, whether it be SDX, so you do the visualization of their breathing patterns to help them, or even people are using the skin surface. So those are other options to look at so that you can make sure that people are taking the breath reproducibly. So deep inspiration breath hold. Look how much it actually brings the heart volume down and out of the field, separates it from the tumor volume. You can see that in the purple there. And then also elongates the lungs. So what ends up happening when it comes to your dose volume histograms is you're actually reducing dose to both heart and lung. So your V20 in your lung is going to go down because you're expanding the volume of the lungs. The other thing for women to consider is actually using an incline board, which actually, when you sit the patient up, their breast tissue may fall down. When you actually lay them flat, the breast tissue may fall up into the field if you're treating with mediastinal disease. So it's an important thing to think about is actually how you're positioning your patients. I know some institutions do scan and scram where the doctor is not there at the time of simulation. I'm there at every single one of my sims just for this reason. I want to make sure that I'm positioning the patient to make sure that I can reduce whatever the late toxicities are. This is a butterfly technique that has been used. I'm not a huge fan because I do think, and even in this picture where they're showing a woman, I think you get a little bit more low dose, but it is an option for patients as a way to kind of reduce some cardiac toxicity. And here's a beautiful plan that I did with protons. I missed my proton beam. Okay. All right. So very quickly, because I'm looking at the time, we've got some stuff that we just need to cover. Malt lymphomas, again, very, very common. Ocular tumors are ones that we see most commonly. And we saw some pictures of this in the skin where you can actually do this very, very nicely using internal eye shields. As long as the internal eye shields are lensed and have plastic, you do not want to cover, for conjunctival malts, you do not want to cover disease. So please don't just put a full-on, internal eye shield that's made of lead or whatever into the eye because you might actually block tumor. Okay, so if you're using electrons, so that's the only caveat that I have there. Obviously, malts can be in other sites, but one of the things that we oftentimes are kind of called in for is gastric malts. If there is H. pylori, remember that triple antibiotic therapy, actually triple therapy works if there's H. pylori, unless there's a translocation. So again, molecular genomics is coming into play here. If there's a T1118, that translocation actually predicts that patients are not going to have a good response to antibiotic therapy. Will it hurt to give it a 2-week course? No, but then you're actually subjecting the patient to another EGD, right? So you're going to have to get repeat endoscopy to actually show whether or not there's been disease response with that. And so if you know that that patient may have poor response, then why not just go ahead to it? I'm going to pass through follicular lymphoma. The one thing that I must say, again, 24 gray, 24 gray, 24 gray, it actually works. It's very, very good. Except for patients who have poor performance status, that's where you're actually going to come in with the 2 gray times 2, or on facial lesions. I've had patients who have really big, bulky nodes, and I'll just do 2 gray times 2, and they respond really well. You can do it in the eye as well. That's another way to do that. And yeah, so this is where I was showing overall response rates of 92%. This is actually for cutaneous lymphomas. I know we already had skin, but what I love about this is you see this guy's scalp. How do you treat that? Hopefully you guys wouldn't do it with photons, right? Electrons aren't going to work too well. So what I do is brachytherapy. So brachytherapy can be used for cutaneous lymphomas as well. Finally, let me just, I'm not going to go through the solitary plasmacytoma. One of the things that's important, again, is making sure that we're using all of our tools to appropriately stage patients. And the reason why is because you may get asked to see a solitary plasmacytoma. Please ask if a PET scan was obtained. When I was in training, we used to say that 80% of patients with a solitary plasmacytoma of bone would actually progress to multiple myeloma within 5 years. And the reason why is because we were doing skeletal surveys, right? Now we have molecular imaging. We use the imaging that actually is going to show you whether or not you have something that's absorbing and metabolizing. And if you have something, it actually now we actually are able to better detect patients who are appropriate for treatment of solitary plasmacytoma with 44, 45 gray of radiation therapy, and only about 50% of people who have appropriate staging will actually progress to multiple myeloma in 5 years, okay? So I am going to leave you there. If there are any questions, you just got to embrace the beam in whatever form it may be, okay? Make sure you're doing that. And I have to say, go Pats. Thank you. Not fair. Lally's not even here. Whatever.
All right, we're going to start taking some questions. Can you all turn on the microphones, please? Thank you. Okay.
A great talk. One of the things that we face, as you mentioned in passing in lymphoma, or we call it lymphoma, myeloma, tumor board, is this entity or cases that after a few cycles of chemotherapy, and then you see residual disease, and your medical oncology colleague will tell you, we have second line. Then I will tell them, real therapy is one of the most effective treatment. What data do we have to tell them to compare upfront radiation in that setting versus a second line chemo?
Yeah. So that's a great question. And I think the challenge is we don't have a whole lot of great data. And that's our fault, right? We don't have a lot of great data showing the benefit of radiation therapy as second or third line. There are a couple of great things, and I don't know if I should. So the ACR Appropriateness Committee for Lymphoma actually has several articles out that actually have some data, and it's all retrospective, right? So we're not going to be doing it in a prospective clinical trial looking at use of radiation therapy as, after second or third line therapy. The challenge also, when you have had patients who have gone through second, third, fourth line therapy, those tumors are so refractory, and then you're going to come to me, right? So of course you're like, you tried radiation, but it didn't work. But remember, and Dr. Eng had in one of her recent papers that you've got to use doses of at least 40. Right? So in the setting of refractory, multiple refractory disease, 40 gray or more is really required in order to get the same response. But your question but I have colleagues of mine who don't like radiation at all because they've been trained to say radiation is bad, and so they're like, well, what data do you have to use it in the upfront setting? I was like, are you friggin' kidding me? We've got mint recover. Even in the rituximab era, we have tons of data to suggest that the use of radiation therapy, particularly in the upfront setting, is key. And so then thinking about logically the fact that radiation therapy, and I remind them, you do know that radiation therapy was the first thing to cure lymphoma, right? So we just have to be at the table and keep hammering that in. Good question, though.
Next.
Hi, Fulker Stieber, Winston-Salem, North Carolina. How are you? Question about sort of a variation, actually, on one of the questions that's on the SAM sheet. If you have a stage 3 patient with bulky disease and they have an incomplete response to 6 cycles of chemo, but they tell you that they're not going to go on to any other systemic therapy, is there then a role of any palliative radiotherapy to what's left in any way, shape, or form, or do we just wait until they progress and then treat that? That's always a tough one.
Yeah, so I actually, those patients, you need to give them some radiation, right? And usually most of the time you get a mixed and a variable response, right? So oftentimes in these stage 3 patients, most of the disease will go away, but then they'll have like 1 or 2 sites that are funky. We actually just had a patient like that. It was weird because I think he had some sort of cystic component of his disease. And so when you see that and there's a little bit of uptake and the patient's like, I am so done with chemotherapy, I actually just consolidate whatever the sites are that are left. So I treated a neck and an abdomen, and it's okay to do that. Again, radiation therapy works. And so in those settings, instead of using the 30 gray, I bump up the dose, right? So what I've done, for patients who have a PR, I tend to go to a 36. If they've had still a big bulky thing like my patient is, then I take it to more of a 40 gray dose.
Thank you.
Yeah, good to see you.
Take some more questions.
At the mic?
Okay. You mentioned kind of in passing about the double hits and triple hit lymphomas. How do you integrate radiation therapy into those challenging cases?
Yeah. So most of the time with a person who has a double or triple hit, they're almost treated like Burkitt's, right? So it's almost like a Burkitt's light. So in that case, radiation therapy typically is not utilized unless a person has a PR, right? And then you can actually kind of come in and consolidate. A PR or even bulky, but again, depending on what they had, if they've had like dose-adjusted R-EPOCH, then I kind of follow more of the Dunleavy paper, and I won't consolidate if they have a CR. But what you'll see is there is some talk in the literature, even for those patients who have a double or triple hit, in the upfront setting, doing 6 cycles of a Burkitt-like regimen. So whether it be, I've seen people do, R-Codox, MIVAC, right, really intensive chemotherapy, but then going on to autologous stem cell transplant. So they're getting very intensive therapy. And so in those cases, I actually reserve radiation therapy unless they have a PR or if they relapse after chemo.